Good afternoon, and welcome to the Division 47 webinar entitled Beyond the Textbook, Lessons Learned While Working with Athletes with Eating Disorders. All participants are muted throughout the webinar. Please submit any questions using the Questions tab. Questions will be answered within the last 15 minutes of the presentation. And now we will have an introduction of our speakers by Marina Galante.
Welcome, everyone. Today's webinar is entitled Beyond the Textbook, Lessons Learned While Working with Athletes with Eating Disorders. This presentation is hosted by APA Division 47, the Society for Sport, Exercise, and Performance Psychology. I'm Marina Galante. I'm one of two student representatives for Division 47, along with Ryan Sappington. And so on behalf of the division, we'd really like to welcome you all to today's event. We're really excited and grateful to be hosting this webinar and for the contributions of our panel today. We have three presenters, and we will leave about 15 minutes at the end of the presentation for a question and answer session. So as questions come up during the presentation, please feel free to send them in using your webinar control panel. For anybody who's unable to join us today, the webinar will be recorded and posted on the Division 47 social media pages and the listserv in the next coming weeks. Lastly, Division 47 will be live tweeting during the webinar, so please follow along with us on social media using the hashtag #AthleteEatingDisorders. We have a really amazing panel of speakers for today's event. The presenters today include Dr. Jessica Bartley, Dr. Sharon Cherban, and Dr. Riley Nichols. Jessica is the director of the Center for Performance Excellence and a clinical assistant professor in the Sport and Performance Psychology program at the University of Denver. She also provides clinical and performance psychology services to collegiate, professional, and Olympic athletes, including eating disorder treatment. And so Jessica will be speaking on the basic building blocks for athletes with eating disorders. Sharon is a sports psychologist at Boston Children's Hospital Division of Sport Medicine, where she specializes in treating clinical eating disorders like anorexia, bulimia, and binge eating, and she helps build recovery programs to confront self-sabotaging behaviors that impede healthy relationships and a happy, wholesome life. Many of her patients are elite and high-level athletes and dancers who also seek her out for her eating disorder expertise. And Sharon today will be presenting on the many faces of athletes with eating disorders. Riley is a counseling and sports psychologist and the director of the Victory program at McCallum Place, which is the nation's only residential eating disorder treatment facility specifically for athletes. Dr. Nichols maintains a private practice where he primarily works with athletes addressing clinical, eating, and performance concerns. And today, Riley will be discussing the role of multidisciplinary treatment teams and themes of treatment. Here are the learning objectives for today's webinar. So presenters will provide an overview of the literature on eating disorders and athletes, highlight clinical themes, and help attendees understand treatment options and targets for the athlete population. So at this time, I'd like to turn it over to Jessica.
Great. So thank you so much, Marina, and thank you to the American Psychological Association and Division 47. We're really excited to have this webinar on this really important topic. So as Marina mentioned, I'm Jessica, and I'm currently a clinical assistant professor and director of the Center for Performance Excellence at the University of Denver. I've been working with eating disorders for more than a decade, beginning in graduate school at ED in Denver, also through several university counseling centers, including Ohio State and the University of North Carolina. At ED I worked with some incredible colleagues to create a program specifically for athletes with eating disorders needing a higher level of care. Currently, I'm working on a book with one of my colleagues at ED Dr. Melissa Strano, and I work, as Marina said, with some Olympic and professional athletes struggling with eating disorders and disordered eating. Since this webinar is called Beyond the Textbook, I really just wanted to jump in with the notion that most of our participants have a basic understanding of eating disorders and are interested in learning a little bit more than what you could learn in a book. So therefore, I really wanted to just talk about the basics and the building blocks of athletes with eating disorders. And I wanted to set the stage for the remainder of the eating disorder. So our first slide. So this slide and the next slide, what I really wanted to do was just give you some literature on the complicated landscape of athletes with eating disorders. So as you can see in this first slide, there's some journal articles that address athletes with eating disorders and point out that athletes are often at no more risk than the general population when it comes to eating disorders. Some of the literature even says that athletes are at less risk than the general population. And anecdotally, we know that sport has some incredible benefits for athletes and can actually be protective factors for athletes developing eating disorders. So our next slide. The next slide, this one really highlights some literature that athletes, and often athletes in particular sports, are more at risk than the general population relating to eating disorders. These sports are often categorized as aesthetic sports, lean or endurance sports, power to weight sports, anti-gravity sports, weight category sports, or high intensity sports. You know, this also really summarizes that athletes who have trained in their sport since childhood, athletes that have a coach who might focus on wins and losses as opposed to an athlete being a whole person, they're also at risk, greater risk than the general population for eating disorders. So I had these two slides really crammed full of information just to highlight there's a lot of mixed information. And I've worked with a lot of athletes in ball sports, so soccer, basketball, in their treatments, and that's actually who I've worked with the most. And so, you know, I don't know if that's because their teammates push them into treatments, but the literature is really, really mixed. And I think that I just wanted to highlight that because I didn't want anyone to have any notions going in that there's one particular athlete that we need to be worried about and other athletes that we don't. So on the next slide. What I really wanted to do is to just have a list of the types of eating disorders. And I wanted to say that you're going to see all of these eating disorders on the slide in the athletic population. So there's not one that is absolutely more common than others. I didn't want to spend too much time on the different types of eating disorders, but what I really wanted to highlight is that some of it looks a little bit different in the athletic population, and sometimes it looks exactly like it does in the general population. So you might come across a female lacrosse player who's struggling with anorexia. Maybe she's restricting, maybe she's not. With bulimia, I really have learned to look at it a little bit differently. Sometimes we think of vomiting or throwing up as one of the behaviors. And, you know, in athletic populations, you tend to see a lot of overexercise and a lot of, oh, you know, just one more rep or a few more reps or a little bit more cardio and I'll be a better athlete. And unfortunately, it's often praised by a parent, a coach, or a teammate. So I think those are just really important things to highlight, is that it might look a little bit different and it might not. And for binge eating, this might sound a little bit more stereotypical, but I've worked with a lot of linemen in college and professional athletics with binge eating disorder. And so it's definitely a disorder that you will see in an athletic population. And it's so easily masked by the needs of their sports. So being a heavier weight can often be a huge benefit in their sports. A couple of other things that I wanted to jump down that are not actually in the DSM too is orthorexia. So orthorexia is just restricting your diet to promote health, but it often paradoxically leads to really unhealthy consequences. So cutting out gluten or cutting out dairy or soy, or, you know, in order to be a little bit more healthy, it ends up really becoming unhealthy because it's controlling a lot of what you do on a day-to-day basis in a really unhealthy manner. That can often happen a lot with athletes. There's also something that you'll see in the literature called anorexia athletica. It's not in the DSM, and it can also be known as compulsive exercise, sports anorexia, or hypergymnasia. It's most commonly found in pre-professional and elite athletes, but it can also exist in the general population. It's characterized by excessive and compulsive exercise, and it's usually around a sense of control because they're not able to control other things in their life. Unlike anorexia nervosa, and why it often doesn't meet requirements is because body image doesn't seem to be as much of an issue. It has a lot more to do with performance, but again, can be a very serious psychological disorder. So just wanted to highlight a few of those while you're looking over the list for the types of eating disorders. And next slide. One of the things I also wanted to show you that is specific to the athlete population is the female athlete triad. So it was first described in ACSM, so American College of Sports Medicine meeting in 1993. And it is a syndrome in which there's disordered eating or often energy deficiency, menstrual disturbance, and decreased bone mineral density. So osteoporosis or osteopenia. And it can present in varying degrees. So if an athlete is suffering from one of the elements of the triad, they're likely suffering from the other two as well. And it's a pretty serious condition that can be specific to female athletes. So in 2014, the International Olympic Committee, the IOC, they had a working group that coined the term relative energy deficiency in sport, so the red S. And so I've also included that on the slide to really emphasize that the syndrome can affect all athletes. Interestingly, there has been a controversy regarding the IOC statement on the red S. The Female Athlete Triad Coalition actually refuted this statement in 2014, saying that it does not place enough emphasis on the female athlete triad. The female athlete triad is really well researched and improves health outcomes for female athletes. By contrast, the authors of the IOC statement on the red S recommends that sports medicines and sports science communities work together to increase the understanding of the red S. And so as you can see, there's a little bit of a back and forth. And I actually didn't know quite as much about that until I really looked into it. And so understanding that there's these two different concepts, I think is really important. And so something that I wanted to highlight when you're looking at working with populations, so that there's not one right or wrong concept, but that there are two out there and they don't necessarily align very well. Next slide. So finally, I really just wanted to post on the different levels of care for eating disorders. And we're going to get into that a little bit later in the webinar, but I really wanted to talk about this because I think getting the appropriate level of care for an athlete with their eating disorder is crucial. I feel that an athlete needs to be motivated for the level of care. So when I work with an athlete, I tend to educate them first a little bit on what we call a biopsychosocial model for eating disorders. So there are biological components, psychological components, and social components. Honestly, a lot of people don't know about the genetic or the biological components that really accompany an eating disorder. So I start there, and then I would really, it might sound counterintuitive, but I tend to congratulate an athlete on finding something that works. So I've found a lot of the times that when I work with athletes, they really developed their eating disorder because it was something that worked for them. So they were able to manage their weight, they were able to perform better. There's some sort of ritual with eating that has improved their performance or their status. And so I typically look at what is that and why. And I think oftentimes then I work to collaborate with an athlete to find something that works better. And so usually they're coming in because something has stopped working. And I find that often with athletes, when they come into treatment, they tend to be a little bit worse than the general population. And the research actually supports that they end up coming in with greater symptoms, but they often recover a little bit quicker. So finding the right level of care is really important. And so while I don't want to go into detail for what each of the levels of care are, they're progressively in order, starting with outpatient. The APA actually has some great resources on level of care. And so I think it's really important to find the appropriate level of care and find the right practitioners or group of practitioners and really a multidisciplinary team when you're looking at treatment for an athlete. So that's what I have, and I'm going to pass it along to look more at levels of care and some of the different faces of athletes with eating disorders.
Unmuting myself. Thanks, Jessica. That was such a great lead-in. Hi to everyone else who's joined us today. Both Riley and I are fresh off the ED and Sport conference from last weekend, and so a couple of my opening remarks. Marina, we can go to the next slide. I'll be talking off of one slide for this section of the webinar and then come back at the end after Riley presents and get into a couple of case vignettes that demonstrates a few of the points that I'm going to be making on this slide. So since we are doing more of an advanced conversation about treating athletes with eating disorders, I think Jessica did a really great job again at highlighting the gray area. So a couple of the points I wanted to make even before I get into these different ways in which athletes can end up with an eating disorder is to think carefully about avoiding generalizations. There were a number of talks that I sat through even this past weekend where we are all in the field treating athletes with eating disorders, and we can all end up falling prey to making generalizations or absolute statements. So a couple of absolute statements I heard this weekend is that athletes are special. They are. They, on the one hand, do have unique needs, but I think if we think of them as overly special or absolutely unique, also to Jessica's point, many of our athletes with eating disorders look just like every other eating disorder patient who might share the same, residential setting. And so I tend to try to walk down the middle of both recognizing that when we're working with an athlete population, having providers who are trained and thoughtful and sensitive to the culture of what it means to be an athlete at the level that they're an athlete. So if they're a developing athlete between the ages of 8 and 18, or they're at the national level, that having a provider who appreciates the context of the demand of not only the level of sport, but some of the unique aspects of the challenges in their sport without falling prey to generalizations or assumptions continues to be a challenge even for us who are specialized providers within the eating disorder community. So it's just continuing to be a word of caution, and that we all have to keep challenging our blind spots when it comes to this particular population, which can be incredibly rewarding, but as I will share later, they're also some of my longest to recover patients as well. So to Jessica's point that we'll find that motivation can be incredibly high in this population to get to recovery and return to sport. And again, to quote a statement that was made, I always use exercise as carrot motivation to return athletes to sport. And I would just challenge that notion that there are many athletes that works for, and for others, it's particularly frustrating when they watch a season, an entire college experience, and a career pass them by because their eating disorder is much bigger than their athletic identity. And so I want to keep talking about sort of the exceptions and the nuances, given that this is to be a bit more of an advanced conversation. So I'm going to explain what I have summarized in previous work as the areas that I see as vulnerabilities for athletes. And again, it's to kind of confront these assumptions that we make, that it's aesthetic sports, or it's long distance runners, or the assumptions that are made about who and what kind of athlete has an eating disorder. So I'm very interested in what I call high commitment eating. I support it. and within the traditional eating disorder community, the idea that athletes will have to make a commitment to a certain type of nutrition that may be guided by a sports dietitian or by a nutritionist, yes, it can be a risk factor to opening the door to eating disorder. High commitment to sport opens the door to compulsivity in some particular way. And so high commitment eating gets rewarded and is part of the sport culture. And it can be one of the doors that opens to dieting or anxiety about expectations. I worked with a synchronized figure skating team. They would pretty much get to Worlds every year. And when they ate as a team, they were judged if they didn't eat broccoli and chicken for dinner. That sets up both an expectation by the team of what's expected in terms of staying lean for your sport, but it potentially also opens up reactive behaviors like binging and anxiety and internal conflict if the individual skater is someone who can't live by the rigid food rules of a particular team. Body dissatisfaction is another door. There's some, again, some areas that I'm very interested in is that we can have contingent self-esteem based on appearance. We can have contingent self-esteem based on our athletic identity. And so some people will say to me that I have body dissatisfaction when I'm in my sport, and then the rest of the time I feel just fine. And the fact that there is a nuance to self-criticism and comparison in the particular arena, that it's not just widespread body dissatisfaction that might sound true in our general eating disorder population. Within the athletic population, the comparison can often be just actually specific to sport. Weight metrics, a quote from my practice yesterday was, "I missed the days when I was a swimmer and my weight didn't matter." This was a very competitive swimmer who decided to switch to rowing, and her demographics lend her better to be an open lightweight rower, and she goes to Worlds when she's competing U23, but she hasn't been able to be voted at the college level because her weight and height is always an issue. So she's developed eating disorder symptoms. She's driven to have to actually do some compensatory weight gain in order to actually get voted. And she was a very competitive swimmer, so I'm still scratching my head, except that both parents were world level rowers, and I think she switched sports to potentially gain their approval. But it's pretty powerful when a swimmer who we also think might be susceptible to body stuff because of the bathing suits and the attire, and as well as the body composition, she misses the days when weight wasn't relevant to her sport. So that's going under the weight metric example. Whenever we start to take weights, we open the door to creating anxiety and distress and potentially symptoms. I presented last weekend on achievement by proxy, so I'll just make one statement about that, which is we need parental support and coach support, as well as some identification in the talented athlete. When that becomes distorted, or there's some risky sacrifice, or the athlete is valued for what they do and not who they are, that then also becomes a contributing factor to vulnerability to eating disorder. Sexualization and self-objectification as well opens the door to eating disorder, because it can contribute to body preoccupation, as well as focusing on appearance and attractiveness, both inside and outside of sport. Trauma inside and outside of sport, we've heard a lot about USA Gymnastics. While we haven't sort of talked about anything explicit that one specific trauma has led to an eating disorder, trauma is highly associated with eating disorders, and many of our athletes are coping really, really well. And as Jessica said, not just through their eating disorder behavior, but that being in sport is often a coping strategy for having dealt with or managing some kind of trauma from childhood. And an injury or a challenge to one's athletic identity can then have the athlete have to confront trauma that came with them, or trauma that's occurring within the context of their sport. Career transition and injury, another vulnerable time, and this correlates with athletic identity. So Marina, you can just switch to the next slide. So when there's a loss of athletic identity, I don't know if this slide is really light for you guys, but there's both involuntary and voluntary, and both types of transition within athletic identity can actually create vulnerability. Even when there's a perceived sense of control in the decision-making, the grief process, the mourning of the former athletic fit body, coping with body adjustments, post high-level training, are all ways in which athletes can be susceptible to eating disorders. Riley, over to you.
Thanks so much, Sharon and Jessica, for that great lead-in. I'm going to be discussing primarily three overarching themes in my section of the webinar here, and really hope I don't grossly oversimplify some of the complexities with some of these issues, but for the sake of time, we're trying to do our best here. So go ahead and next slide, please, Marina. So the first is that your action or inaction communicates a powerful message. I think most of us are pretty familiar with maybe some of how an eating disorder presents itself, but then I think it not much, at least I wasn't really informed about kind of what to do from there as a coach, as a provider, as a parent. And I think it's just really important to know that our action or inaction is extremely powerful to the athlete. And I'm struck, I have the kind of vantage point of being embedded in the Victory program here, which is intensive treatment. And I'm struck by the number of athletes who come through our doors who are quite compromised in many facets of life and health and wellness, and yet little to no person or hardly anybody has communicated their concern for the athlete's compromised state. And I think that largely, I would imagine, comes from two different reasons. One is just not wanting to say the wrong thing, and then secondly, not wanting, potentially the athlete to get defensive or upset. But in actuality, that inaction communicates that either you don't care about them as a person, or some of the struggles that they're dealing with are not important and don't warrant further evaluation. And obviously that couldn't be further from the truth. But I think inaction kind of communicates that as well. Division I runner who is currently in our care said in session to me last week that and this presents itself too, even when an athlete is embedded in treatment. So is it plugged in with an outpatient treatment team, has a coach, obviously, everyone who is aware of her eating disorder and struggles. And she said to me last week, I really wish that my therapist and dietitian and coach would have upheld the contract that we put together and agreed upon last year. And she said, I wish we could go back in time and have kind of those parameters be enforced. Problematically, what happened was that she was running really well, and over the course of last year set several school records. And I think that every provider that had touch points with her, including her coach, had kind of a false sense of wellness and health because she was running so well. And this is something we see often. The body is tremendously resilient and can perform well for a window of time, and for her that was happening. And what that does is that prolonged her getting the level of care that she needed, and now she's in care for much longer than I think she potentially would have needed to be had some of these agreements and parameters, specifically with just meal plan adherence and weight parameters and other things too, been kind of really firm by all and upheld by all members of the team. So that's it. Inaction. And I also think the message that it communicates is that we value you as a runner and what you can produce and contribute to the team and to the school more than we do as a person and caring for you as well. So although that obviously isn't probably how her treatment team or coach felt, that I think is the message that is being sent by that inaction. Also too, kind of during care, I guess, so that is kind of more inaction. In terms of taking action, I think a lot of thoughtfulness needs to be done about how that is done, and what is the message that's being communicated to the athlete. What's the setting that this meeting or these conversations are happening, and I think that a lot of thoughtfulness and intentional effort needs to be directed around when action is taken by a loved one, by a coach, by a provider as well, because sometimes everyone hits the panic button, and I think everyone is well intentioned, but how things play out, I think it can be really aversive and quite off-putting too for an athlete in a vulnerable state, obviously. So just want to kind of make you aware of that. And I think we all know the relational equity that you put into an athlete, I think is, or have with an individual, is paramount, and I think will allow you the opportunity to have some direct conversations. And I think if that relationship isn't built and solidified as a strength and conditioning coach, as a dietitian, as a coach, as a provider, I really think that is going to jeopardize, and an athlete is going to have a harder time really trusting you, and especially when you're being asked to do something that's not on life's bucket list in terms of going to treatment or get additional care. I think awareness and timely response is paramount to treatment, and there is an urgency to shepherding an athlete to get the appropriate care. And so I think that sometimes is needed as well. And so that takes some action and looping people in on your end as well, in whatever role you might have in an athlete's life. It shows you're invested and committed to their well-being and their care and their health. I think too, action in terms of what warrants a higher level of care, and I think there are specific guidelines, as Jessica outlined, that the APA has come up with what warrants a higher level of care. But as having these touch points with the athlete, I think knowing and trusting your gut, that and recognizing kind of where's my endpoint here, and what do I feel comfortable with for this athlete persisting in this level of care if it's outpatient. And then I think a higher level of care is obviously warranted when progress isn't being made or symptoms are deteriorating further. And I think too, so I think, go ahead and go to the next slide, Marina, please. This is kind of just a summary, and you can certainly, the messaging I think is key, especially as a team, consistent messaging. Sometimes messaging as a provider is consistent and parallels kind of messaging from the sport world, and other times they kind of seemingly go in opposition, and I think that's always challenging as well. I think the training and exercise parameters is extremely important, especially working with an athlete population, and identifying somebody to oversee that, to modify those and adjust in a very fluid manner and responsive manner is important. Next slide, please. This is something I think is just good practice just in general, but I think remaining within your expertise and utilizing appropriate resources. I think there's tremendous danger and risk associated when we veer from what we know and what we're trained in and what we're competent and sometimes licensed to do. And I think that if we're not competent or able or knowledgeable to provide a certain service, if that's nutritionally, psychiatrically, clinically, I think there are resources out there, and I would just really encourage you, if you're working with an athlete, to really familiarize yourself with providers in the area, locally or nationally, that maybe have the knowledge and expertise that is needed to round out an individual's care. I also think too that oftentimes individuals are very well-meaning and mean well, but I think overstepping kind of your area of expertise and veering outside your lane can really have some pretty significant consequences, which we've seen many times in athletes in our care as well. I think too, just in terms of expertise, I think there are a lot of nuances, as we've discussed so far, just in working with the athlete population for individuals struggling, and what sometimes might be reinforced in sports, such as putting in a lot of extra training or hours in the gym. I think oftentimes can be rewarded and supported and acknowledged by the coaching staff and athletic personnel and even teammates, but oftentimes too is folded into an individual's eating disorder as well. And there's kind of an unwholesome clinging and unbalanced relationship with with exercise too. So just I think there's just a degree of sensitivity, I think, with this population that is just really important. And I think just recognizing that an eating disorder is a metabolic injury, and I think thinking about it as such would really informs the care that is provided, and reintegrating an individual, should it be appropriate and should they desire to do so, back into their sport. And like any physical injury, expediting that process and rushing that process prematurely, whether it's with training or reintegrating them back into school and sport, really heightens and elevates the risk of re-injury or relapse as well. And then I think also to avoid oversimplifying eating disorders. I think these are a complex psychiatric issue, and I think oftentimes athletes hear things that feel very dismissive by individuals who care about them and love them and are well-meaning, but I think there's a tendency to grossly oversimplify eating disorders, and so just to avoid doing that, I think would be quite advantageous to an athlete's care. Next slide, please, Marina. These are just some recommendations. Again, just kind of not at all a comprehensive list by any means, but just recommendations for a treatment team. And I'll go ahead and go on to our last kind of theme here. And I think this is something that really resonates with me in my work clinically that I could talk an awful lot about. But oftentimes a theme that I see in my clinical work with athletes is really this high self-punitiveness and criticalness, and an inability to be compassionate and patient with oneself. And so oftentimes a treatment target or goal or objective is to really try and cultivate self-compassion. And sometimes you say this word and you'll get some eye rolls, and feel quite aversive to be patient and compassionate with myself. I had a track and field athlete this week, actually, when we were talking about this. She said, well, I feel like if I'm being compassionate with myself and patient with myself, then I'm lazy and not motivated. And again, just trying to kind of work through that both can coexist. You can still hang on to the fact that you're highly motivated and committed and dedicated, but that doesn't mean you have to be withholding of compassion and patience and grace with yourself too. So that's something that perfectionism is oftentimes off the charts with a lot of athletes that I'm sure many of us work with. And I think that suits individuals quite well in their sport, in school, in relationships, but it also too leaves little to no room for tolerance of struggle and challenges. And so it's trying to help, especially the athletes in our care, to develop a greater ability to tolerate struggle. And that's really challenging as well. Two more things, and then I'll go ahead and turn it back over to Sharon, would be just the ability to over-identify with their sport and eating disorder is something. And Sharon mentioned that contingent self-worth and self-esteem is something that we see often, and are often trying to help an individual or an athlete kind of develop a more robust sense of self and expand their identity, rather than being unidimensional in their, of course, eating disorder, but also too as their athlete identity also. And lastly, one of the kind of aligns with that self-compassion and fostering that is just to identify the role of fear in an athlete's eating disorder. And I think oftentimes there's a belief that I am, putting in a lot of extra effort training or eating a certain way, or because I'm motivated, I want to kind of really enhance my performance. And I think that is true, but oftentimes there's fear kind of intertwined and enmeshed in there. So it's kind of teasing that out and really acknowledging potentially the role of fear. And we see shame as well, pretty integral in a lot of the work that we do with the eating disorder population, especially in sport as well. Next slide, please, Marina. So these again are just kind of some of the things. Again, we could talk for quite a while on each of these, but some of the themes that emerge, there's certainly more, but these were just kind of resonated with me and something that I see frequently in intensive treatment and in my outpatient practice. So I'll go ahead and turn it back over to Sharon, who's going to talk about a case or two before we wrap.
Okay. Next slide. Marina, we'll start with that first case slide. Yeah, my slides are pretty hard to read. So though I want to make two comments before I jump into this. Another concept that comes to mind that I think is relevant for all of us to keep thinking about is, how do we measure recovered and return to sport? Like, unlike an ACL tear, where there's, even though it's a long recovery, there's a linear process, and we know when an ACL is recovered and when it isn't. Return to sport doesn't necessarily mean that the athlete with an eating disorder is recovered. It means that they're recovered enough to return to sport, or to return to exercise, or to kind of reintegrate that process. And sometimes that recovered status is given to someone when it's incredibly hard to measure. Something I've become interested in more recently, especially as I've consulted with the Goals program, which is one of the other IOPs dedicated to athlete programming, is I'm often thinking about both patients who want to be spokespersons, as well as programs who would like to have athletes maybe represent their experience in a program. And I don't know if there are any good tools out there to actually measure recovered and psychological readiness to be sort of a media spokesperson, but it's something I'm particularly interested in, is protecting not just the exploitation of our very special population, but also they're unknowingly exploiting themselves in this blogging and sort of using public platforms as part of their recovery, but at the same time not being fully aware that they may not be recovered. So this case is someone who's ongoing. She was a competitive gymnast, and she's been to ED Care twice and restored weight, both times sort of on a contingent basis by her own sort of self acknowledgement. So she exited so for the rest of you thinking about higher level of care, ED Care is a PHP level of care, and it does have specific athlete tracking. She found the appeal to going to a program that was both designed for athletes, but also not quite as restrictive as McCallum, where it was residential, appealed to her sense of autonomy, as well as the specific programming. And she navigated time 1 and time 2 differently. Time 1, like many patients go to treatment, it was required by her school and her athletic team that she go to a higher level of care. She ate to get out, which is what happens in a lot of recovery processes. She decompensated pretty quickly, never made it back to school or back to her team. When she did treatment the second time around, it was a much more sort of challenging experience for her. We did things differently, tried to challenge what some of her resistances were. She did a touch better when she left treatment and stepped down to the Goals program and held on to a decent body weight. We started to restore her to supervised strength and conditioning. And there was a tipping point where as soon as she started losing weight, she was not able to regain it. In her case, there's, especially with family members, there's been a lot of dangling of that carrot to get back to school and to get back to her team. And she's now in year 3.5 of her recovery process at the lowest weight she's ever been at in her life, unable to choose treatment for herself, unable to use any of the motivation that we've been describing for all the things that she's lost in her life, like her education and her opportunity to compete at the collegiate level. So what I have highlighted is she was a competitive gymnast that was body composition sensitive. She trained at a very high level with a Russian coach that used shaming tactics. If she did not complete a move to his satisfaction, she would sit in a corner facing a wall. When she started to encounter mental blocks, like a very normal time frame that we see in competitive gymnasts, it's usually like level 7 or 8. And that 12-year-old brain starts to come online and starts to perceive risk. And if you're at all an overthinker or slightly obsessive compulsive like this particular young woman is, she experienced a tremendous amount of shame around the mental blocks. I believe that one component, like one tipping point that has led to this particular eating disorder started back then, and she hasn't forgiven herself for her failure around her inability to work through those mental blocks and quote unquote be strong. Achievement by proxy applies to her. She's the athletic and academically talented kid in the family. The parents have highly invested in her, both in her athletic talent as well as in her academics. So much so that even at a heart rate of 38 and body BMI of under 16, which for some of you would know, that's like at the hospital level admission. Family was still valuing education over treatment because they still think that that's going to basically get her back to her life. And her perfectionism, as we've all described earlier, is off the chart and absolutely an obstacle to her recovery. Marina, go on to the next slide. I'm going to just hit one more, and then we're going to leave things open for questions. So MW is a completely different story. She came to see me after she finished a master's degree in counseling, and she was a very competitive athlete all through high school and in college. By the time I met her, she was doing triathlons, comes from a highly competitive athletic family. Her sisters completed 7 Ironmans. And when MW came to treatment, she said, I just finished a counseling program and supposedly I'm going to be working with patients, and my bulimia has been in my life for the last 5 years. I've been in therapy, and basically we talk about my career and we don't talk about my bulimia. I think that you work with athletes, but you also treat eating disorders, so I want you to help me fix this. And she was one of those people who in session 2 agreed to go to treatment. And I made that decision based on the length and the severity of her symptoms. She was binge purging 5 times a day, and that the behaviors had been in her life for up to 6 years. She was highly motivated. Given that she was in the field, she wanted to leave the state. So she went out to Denver as well, but she went to the other one, ERC. And so that's a very traditional eating disorder program. And what I mean by traditional is that they don't treat athletes separately or differently. And whether the exercise restrictions that were placed on her like everyone else. And she had the ability to basically put her athletic identity on hold and valued her recovery process. And just bought into the idea that she needed to disrupt behaviors. She felt like a rock star when she left, just to get 2 months of no behaviors under her belt, and she was limited to 30-minute walks per day. She was told that her outpatient team would progress her back to exercise and sport. And I tell this story because she stepped down to Renfrew in the Boston area as well, and this was several years ago, but as well, no athlete programming. And her exercise contract was that she was allowed to do any kind of exercise she wanted up to 1 hour a day with 1 rest day, which was quite cooperative for someone who is a very active person. So after her first weekend, she came back from Nantucket, where her family has a house, and she took a bike ride with a basket to the lighthouse and back, and then hit a yoga class with her mom later in the day. And when she excitedly went into treatment on Monday morning, saying what she did, not reporting it as exercise or not exercise, she was confronted quite harshly that she had broken the contract, like the exercise contract, and was just kind of like struck by the lack of nuanced understanding that for someone who had been a triathlete, like a 2 or 3 mile basket, island bike ride barely counted to her as exercise. And again, her ego strength, which is sort of a jargon term that I'm going to use, was strong enough that she was willing to tolerate what I do think was some clinical misjudgment at certain moments. And what I said to her is, there'll be a day where we get to just keep progressing you and make all of those decisions for be just between us or with the dietitian on the case. She's gone on to be behavior free for 5 years, and we progressed her with races without metrics. So she, returned to doing sprint triathlons, but no pacing. And she's completed several marathons with a BQ goal in mind, which she's on track for. I consider her recovered, and I will leave it there.
Thank you so much, Sharon, and to our panelists for a great panel. So that concludes the presentation section of our webinar for today, and now we'll move into the question answer session. So we have a couple questions here. The first question is for Jessica. Jessica, you really nicely highlighted the subtypes of eating disorders that were not included in the DSM, like the orthorexia, diabulimia, and anorexia athletica. And so our first question is, how can sport practitioners who are working with athletes adequately screen for these disorders? And are there any benchmark symptoms to be on the lookout for that might be difficult to spot?
Oh, that's a good question. I think that's why consulting with someone who really understands how this looks in an athletic population is probably the most helpful. So I know ED Care has consultation. I think Victory Place does as well. I'm not sure about Boston Children's, but I think most of us are available to consult on what things like this could look like with a particular patient or athlete, excuse me. So, I think it's really trying to figure out what is the goal or the purpose. And I think what I use, or the language I use in my treatment, is what is the function. So why would someone be exercising? Are they getting any sort of enjoyment out of something? What is the behavior for? Are they doing one more lap because it truly would improve their performance, or is that something that again, it feels a little bit more eating disordered? One of my first patients at ED Care was diabulimia, and so she was manipulating her insulin, really thinking that it would get her to a lower weight that would improve her performance. And so it's interesting when you really start to understand why exactly someone is doing something. And like I mentioned during the presentation, I think it's super important to get to understand that piece, because typically it was working at one point, and it's no longer working. And so it's so important to understand the why. There's a lot of assessments out there, like the EAT-26 or EDI. The SCOFF is another one. And so there are these really brief assessments that you can always Google, but a lot of times I feel like they miss some things with athletics. So I think asking what the purpose is behind a behavior or what's going on is going to be one of the most important things.
Thank you. Do any of the other panelists want to comment on that question before we move to the next one? No? Okay, great. So our next question, Riley, I really liked your discussion of the challenges that multidisciplinary treatment team providers face, particularly when the messaging between the treatment team members is inconsistent. So how can coaches, administrators, and maybe other athletic personnel set up environments that model healthy relationships with food and these kind of optimal messages about bodies and performance?
Yeah, that's a really good question. I think, coaches, athletic trainers, strength and conditioning coaches have and sports med physicians have a really unique role in the role of an athlete, obviously. and have the opportunity to oftentimes eat meals, travel, and spend a lot of time with a team and athletes. So I think one of the best things that I always advise when speaking with coaches or sports personnel is to really model a healthy relationship with your own body, and to refrain from kind of fat talk or diet talk, just even with peers or other sports personnel, especially with athletes. But I think modeling a healthy, wholesome relationship with your own body and with food is the most powerful message that resonates with athletes. Obviously, what you say is important, but I think that athletes are pretty perceptive too, and can observe maybe when coach isn't really following through with what they're saying about food and maybe and or their bodies. So I think that's usually kind of the best advice that I think that speaks volumes. And supporting the treatment team's kind of recommendation, I think that is so helpful as a provider when you have sport personnel kind of aligning with your recommendations, and there's not splitting or fracturing amongst the team and the sport personnel. And so I think when we're sending an athlete, obviously a school oftentimes entrusts us with the care of the athlete that we take very seriously and want to uphold. But I think when a school can kind of really respect recommendations and our observations in terms of care, I think that's extremely helpful to an athlete's treatment.
I just want to underscore it, and I think it is a point that Riley made earlier, but I just want to explicate just a touch more, is it really takes a village to help all of our patients recover, both athletes and non-athletes. And so when they're either in a team setting and all of those supports are already in place, like sports medicine and nutrition and a psychologist or a mental health person, teams are sometimes already established in a collegiate setting. In an outpatient setting, pretty much, I don't think that any of us should treat solo. It does take a team, and then it takes a high degree of collaboration. And I absolutely love my partnerships with treatment programs. When I do have to send someone off to treatment, I feel like I'm still part of that treatment team, even if I'm on the outside. So if it hasn't been obvious already, we always include a medical professional on the treatment team. There's some sort of nutrition or sports nutritionist on the treatment team. There's a mental health component. Sometimes there's a group. And then we bump up and use programming when we feel like the patient's not able to recover with that level of care.
Thanks for highlighting who's actually on the treatment team. I think that's really helpful too for providers to understand. Thanks guys for your responses. So our next question here, let's see, Sharon, you mentioned that you want to have providers on the team who are trained and very thoughtful of the athlete's culture. So if providers don't have this prior knowledge already, either if they want to work with athletes in the future or just they don't understand the culture already, what can providers do to get this appreciation and understanding of the culture so they can more effectively work with athletes?
Okay, that's such a great question, and that comes up in the sports psychology world at a broader level, not just specifically to athletes. And it's not that I'm making a pitch for AskPeer to become CMPP because I'm not sure how I feel about that. But what I can say is, not having had an athletic background myself and having chosen to train and specialize to work with athletes, I found that the coursework and the training that Ask sets out for people to become certified, I think is directly relevant to getting up to speed on that population. They go out of their way to kind of reinforce those messages as well as get you the education that you need. Do I think you need to be certified or not? I think that's a completely individual decision that someone needs to make. But I do think that the content is super relevant. Going to conferences, cultivating relationships. Of course, you don't get certified without actually getting supervised time in your own work with athletes. And so it's sort of time on the ground with people and like learning the culture. And it's kind of being multilingual. It's being able to sort of enter a culture that you haven't even been familiar with, like bowling, and say, you know, I want you to help me with my performance stuff. And then you might be working with a ski racer, and while the context and the culture of all of that, you know, at first glance, it's super different. Once you become rather sort of sensitive to those environments, you can kind of see the commonalities and also get up to speed pretty quickly on the language and the goals and the level of competition. And I think that someone can become culturally competent to work with that.
Thank you for that. Anything else to add for those questions or any closing remarks from our panelists today?
No?
Thank you for the opportunity.
Yes.
Yes,
Great. Well, that concludes our question and answer session. So thank you guys all for joining us today. And then just a special thank you to Jessica, Riley, and Sharon for just sharing your expertise and really contributing to this webinar. Just a reminder for the members, this webinar was recorded and will be available for viewing in a few weeks. So we will send out a link to the listservs when it is available. And you can see on the screen, if you'd like to contact any of the panelists for further questions, their contact information is provided there for you. And then lastly, I'd really like to encourage anyone who joined us today in the webinar to attend this year's APA convention in San Francisco from August 9th to 12th. Division 47 will have several days of really exciting programming. And of course, we'll have programming from other divisions in APA. So thank you all again for coming and have a great rest of your day.